do not have a damaged AV node, and I have not run into a patient to verify this with only an SA or only a AV node. How can my SA node die? Who cares? It could be calcified. It could be a heart attack. It could be shot with a blowgun dart. I don't know how that happened, but it just did. It could be old age, and they could just be worn out cells, right? If it goes for any reason, I don't care what the reason is. If it goes for any reason, 40 to 60 beats per minute without interventions. Can we still live? Yeah. Can our heart beat faster when we exercise? Not so much. Are they going to have a bad day? Okay. So if I was a nursing student and I wanted to know anything about electrical activity, I'd say, well, SA nodes are nice. Helps my atrium beat. P, that could be a P wave. Okay. Now, it goes there, AV node, down to the ventricles. Oh, that could be a QRS wave, right? So, or QRS complex. And then after that, we'll have a T, which is the repolarization, right? So we're talking electrical activity, muscles, electricity. When I'm thinking electricity, I'm thinking rate, polarity, regularity, and amplitude. Rate. How fast is that guy beating there? How fast? 100 beats per minute? Well, that's okay. Maybe I have my SA node working still. 40 beats per minute? Ooh, maybe it's an AV node. Or maybe they're just a 48 beater and they're really good athlete. Slow hearts. Polarity. Polarity is this. Did this go up or did this go down? How are we repolarizing, right? Regularity. Am I a regular beater? Am I beating like the march of a drum? What is that called? A metronome? If anybody's in college or music class ever, you got a metronome. It drives you nuts, but your band teacher just keeps saying, listen to that marching beat. Or if you're in the marching band, anyways, if it's irregular, like what? AFib, it's not going to be marching like the beat of a drum. Now, amplitude. Amplitude's a silly one. How high is this spike going? How much electricity just got pumped through that ventricle, right? Amplitude. If this peaks down here, how much electricity is that going? If it peaks high, how much? You know what? I don't care if you know how high that goes. I'm saying, hey, does it look weird? Yeah, better call Barb over. Barb's going to come tell you what it is because she is the senior nurse, as we talked about at some point. These intervals tell us stuff. ER interval, that has a certain amount of time frame. QRS has a certain amount of time frame. Time frame, what are you talking about? Well, this is what I'm talking about. This was from pre-COVID. So 4 weeks ago. You don't remember this, but I sure do. I wrote it on the board and I said, we're going to cover this more later. It's not a huge thing for us to know as nursing students right now. Don't memorize all of this, right? Don't memorize all of this.
Will you post that?
All the slides are posted in Canvas under Exam 3.
Awesome, thank you.
Because I knew that was going to come up. So this stuff, you know, it should look like this. It should have a regular time on it. See this QRS here? Okay, this says QRS is 0.8 to 0.10 seconds. That's how fast it should go, right? Don't you think that if you see this QRS start to widen, that you're like, oh, that looks kind of screwy. I almost said a different word. That looks kind of screwy. Better get somebody over here to come and look at it. Called a wide QRS complex. Remember this P wave here? If something looks funny with that, that means our atriums are kind of messed up. So we might be looking at like AFib, we might be looking at A flutter. We kind of know that terminology, but this is what's going to help distinguish us with what's going on. So I'm saying if we're looking at this, we say, oh, that looks normal. That looks normal. Good. If anything is wrong with it, it's going to look abnormal. See this R wave to R wave, ventricle to ventricle, right? This is time. This is voltage. See how high it is? If this voltage looks too high, then you are going to say, oh, that looks too high. Or if it looks too low, you're going to say, oh, that looks too low. We probably don't. Here's some important numbers that you might want to know. So if there's anybody actually missing from this morning's class or afternoon's class, go ahead and spread the word and say that this stuff is important and it is posted. If I'm looking at a P wave, which is this little guy here, right? Do we all agree? Yes, we all agree. Everybody nodded their head, even the people who have their screens blink. This guy right here should be 0.1 seconds long and 2.5 voltage high. If this voltage is skyrocket, what's going on? If this voltage does not exist, what's going on? 0.1 seconds, right? This QRS wave here, QRS complex, 0.06 to 0.12. You know, if this starts to get into like 0.14, 0.18, 0.20, we're saying, uh-oh, they're steering towards VFib, which, by the way, is a shockable rhythm, not like asystole. Asystole, you do not shock them, even if you have sharks on you. In the water, thanks, John. John's still here. No, John's there. So, our intervals and our little time segments are important. There are normals, right? It's really easy to know what normals are, but once it starts coming to abnormals, we have to be like, don't really know. Looks kind of funny. Let's figure this thing out. If somebody, let's see, here we go. If we have these rhythms, look, see this regular normal rhythm, regular rate, regular rhythm, beating out at a nice interval, right? But then, see AFib? Here's our normal P wave. Look at our P waves down there. We don't really have a P wave, right? Here's our regular rhythm. See how this is irregular? Now, when we were talking AFib a little bit in class, we're saying, oh, these atrium are not pumping well. So maybe we're going to get clots, right? Clots, then we say, oh, clots, oh, stroke, oh, no, clots. Well, how about heparin or aspirin or whatever kind of other medication therapy? You know, I think it's really funny. So I was trying to write a story in regards to everything that you need to know and base it on a fictional character, because that's how my brain works. But I was laughing because, like, if you have somebody, and we always relate like the heart to love, right? That's what we do as humans. And we're like, oh, I fell in love and I saw her and my heart skipped a beat and I could feel it, you know, palpation. And my heart's palpating. It's kind of like that with AFib because, you know, look, it skipped a beat or had an extra beat. You know, you're not getting dizzy, you're not having headaches or nosebleeds or anything like that, but you're like having palpitations in your chest. And somebody who has AFib all the time, they might feel that. Or they might not feel that, but for the new person, they might feel like this flutter or heart palpitations in their chest. It's just funny. I was kind of laughing about that. Here's some more stuff on QRS, right? I said QRS is 0.0. I think the other slide said 6 to 0.12. Who cares? It's a small amount, right? But it can turn into this, ventricular tachycardia, right? Or here's a little VFib over here, because our QRS started widening and it did not give time for our atrium to repolarize. And therefore, now our ventricles are pumping too fast. You see a problem with that? I do. They can't fill up. You could lose the oxygen, starts to hurt, you know, you probably become unconscious, don't you? Okay. Point that out. Oh, so I'm looking at all these irregular heart rates, right? Because this applies to this week's lesson, doesn't it? didn't we talk about a little bit about the difference between a normal heart rate, ST, and an ST elevation, probably heart attack of some kind, a myocardial infarction. If I had a myocardial infarction, is this ST elevation, is that a bad thing? Absolutely. Does it hurt more than a myocardial infarction without ST elevation? No, it hurts just as bad. It just means that the blockage, the electrical pathway is blocked, right? So let's go to this thing, right? So if we have an ST elevation somewhere in here, there's a blockage across here killing our tissue, which means this cannot fire right. So that's what we're reading. We're reading the EKG, how the electricity fires through this. ST elevation, you got your coronary here. Dead tissue or tissue that's not absorbing oxygen anymore will not allow electricity to get it, shock it, fibrillate it. And therefore, you get that rhythm. Right? You get this ST elevation. If you look at this one, QRS, complex tachycardia, and you go back and you look at our heart guy here, you're saying this is firing so quickly, making these contract so quickly. It does not have a time for these atrium to squeeze and get blood into the parts that it's supposed to get to, right? If it's going so fast and not filling up, it's not coming in here to our left atrium, it cannot go to our aorta or through our aorta, our aortic valve, into the aorta, around the coronary and through the rest of the body. You see a problem here? I do. Okay, so ST elevation. Anything important that we should know about ST elevation besides myocardial infarction? Well, it might be caused by atherosclerosis. We talked about that, right? We talked that atherosclerosis is a breakdown of the cell walls and of the veins and arteries, and gathering of cholesterol and triglycerides. Probably should give them some Lipitor. Not if they have liver disease. So all of this relates all the way back to our EKG, first day 4 weeks ago before the COVID crisis, right? Kind of funny that. All right, so we're talking still EKG, but we're also now talking heart failure because, if I have heart failure, that means I'm going to have a poor oxygen flow from my heart, which is going to mess with my coronaries, and it's going to mess with the way my EKG reads, right? So, lifelong therapy, not only do we have to have a non-pharmacologic approach, Simple 7, page 640, we also probably need some sort of pharmacologic approach, right? I said this yesterday, farm in with med-surg, that's a bad day. Wish we were as smart as that class just came from today. Thanks for coming for this hour, by the way. Afterload. Remember, we talked about afterload. That's this pressure here on the aortic valve. You know how to fix that? Give them some ACE inhibitors. It kind of lowers your blood pressure, which makes the afterload lower. Afterload is the systolic pressure. Is that what we talked about? That's what the video said. Preload, nitro. Give them some nitro. It's going to expand or dilate your arteries and your veins. That means not as much blood will come into here as quickly, which means it's going to be easier for this blood pressure to be down. So the afterload will technically go down too. But with nitro, we're thinking a lot preload. Contractility, we talked about contractility and beta blockers, right? Makes it easier for the heart to contract, less oxygen required. And cardiac output, that's the goal, right? We want a good, healthy cardiac output. Can you believe that if we have an increased afterload, our cardiac output will be lower? That's not a good thing. Lowering our blood circulation, therefore lowering the oxygen, increasing oxygen needs. And, you know, double-edged sword. Heart needs it, body needs it. All right. This is the everybody gets to participate phase. Are you ready?